Hi, my name is Quentin Broussard. I am Assistant Professor of Clinical Sciences at California Health Sciences University, and today we'll be discussing ICU delirium. And the reason we're talking about ICU delirium today is ICU delirium is a syndrome that acutely affects hospitalized patients, particularly those in the ICU, costing billions of dollars each year as decreasing quality of life of hospitalized patients, as well as their quality of life after they're hospitalized. Our objectives today will be to explain the pathophysiology and presentation of ICU delirium, to diagnose ICU delirium using different monitoring tools, identify non-pharmacological delirium treatment modalities, and determine appropriate pharmacotherapy considerations for ICU delirium. Then we'll review the current evidence and guideline-based recommendations for the treatment of ICU delirium. We'll start off with a patient case. SW is an 85-year-old male who presented to the ED 1 week ago in septic shock secondary to pneumonia. He was subsequently admitted to the medical ICU. He was originally in respiratory failure requiring full mechanical ventilation, but since then SW has improved and is now being extubated and placed on nasal cannula. He is not lethargic and has adequate motor activity. Once transitioned to nasal cannula, he became very agitated, thrashing around, wanting to take out his nasal cannula and leave the hospital. The physician rounding with you thinks SW may have ICU delirium. Question 1. What type of ICU delirium does SW most likely have? Hyperactive delirium, hypoactive delirium, mixed delirium, or does SW have dementia? Question 2. Which of the following non-pharmacological interventions is most likely to benefit SW's ICU delirium? Staying in bed, avoidance, reorientation, or dehydration? And question 3. Which of the following agents may be beneficial in the treatment of SW's ICU delirium, assuming no contraindications? Sertraline, alprazolam, amitriptyline, or quetiapine? After we talk about ICU delirium today, I hope that you'll be able to accurately and confidently answer each of these questions. So your first question might be, what does delirium actually look like? I know that in context, we may refer to someone as delirious or having delirium, but what does that actually mean in terms of presentation? So if you take a look at this YouTube video right here, this actually shows one potential face of ICU delirium. And the type of delirium that you'll see here is what's called hyperactive delirium, which we'll discuss a little bit further. This is just essentially to put a face on what delirium looks like so you can kind of have an idea of what patients you're actually going to be dealing with in practice. In terms of the delirium definition, the 2013 Pain, Agitation, and Delirium Guidelines used DSM-4 to determine the different domains of delirium, in contrast to DSM-5, which came out a little bit later. For the DSM-4 domains of delirium, DSM-4 defines delirium as a disturbance of consciousness, a change in cognition, a development over a short period, which is key to the definition of delirium, as well as fluctuation potentially. And that fluctuation can be anywhere from the hyperactive to hypoactive states of delirium. The National Institutes of Health defines delirium as a sudden, severe confusion with potential rapid changes in brain function that occur with physical and mental illness. For the epidemiology of delirium, delirium can affect up to 80% of mechanically ventilated adult ICU patients. If you think about the typical population of an ICU, about 1/3 of the patients are mechanically ventilated. And using this statistic, that would mean a significant number of patients in the ICU actually have delirium. Now, just because a statistic mentions mechanically ventilated patients does not mean that patients that are not mechanically ventilated cannot have delirium. The non-mechanically ventilated patients may also have the potential of developing delirium. Delirium poses a significant cost to the United States healthcare system, costing about $4 to $6 billion per year, with increased hospital costs of about $2,500 per patient. And that cost doesn't even include the additional costs for institutionalization, rehab, formal health care, informal caregiving, as well as skilled nursing after the patient leaves the hospital. So delirium not only affects the patient while they're in the ICU or even after their transition to the acute care area of the hospital after their ICU stay, it can also have debilitating effects on the patient after they leave the hospital. Delirium is also associated with increased ICU and hospital lengths of stay and increased mortality. Therefore, treating delirium is of the utmost importance to try to minimize morbidity as well as mortality. In terms of pathophysiology, delirium is very poorly understood. There are some beliefs that delirium may be neurological in cause as a result of GABA or cholinergic neurotransmitter systems. It may be as a result of excess dopaminergic and serotonergic activity, and this will be important to keep in the back of your mind because some of our drugs can actually work on the dopaminergic and serotonergic activity pieces. Other beliefs may be that neurotoxic effects of inflammatory cytokines may contribute to delirium. So one example of this is patients who have infection or have sepsis or septic shock. Whenever you have an infection, you have the potential to develop inflammatory cytokines, and those inflammatory cytokines can go all around the body and not only cause cardiovascular compromise, but also neurological compromise as well. In terms of causes, there are many different beliefs on what can cause delirium. Is delirium disease-induced, like sepsis? Eratogenic? Is it caused by a medication or some other kind of cause? Or is it environmental? Or is it a combination of different things? If you take a look at this diagram that was taken from the New England Journal of Medicine, their belief is that delirium may be caused by many different things. So, for example, head injury may be a cause of delirium, pre-existing mental impairment such as dementia or Alzheimer's disease, other medical comorbidities, severity of illness, advanced age may play a factor or be a potential cause. There are also other causes that us as pharmacists will want to know about, particularly patients who are on sedatives, patients who have substance abuse or substance withdrawal. Also, things such as noise can contribute to delirium. Say if you have a patient who's in the ICU, many alarms will constantly be going off during their ICU stay, indicating that they may have some sort of hemodynamic or respiratory risk. Another one that plays a role is sleep deprivation. Think about whenever you don't get enough sleep and how you feel mentally after you don't get enough sleep. Patients in the ICU do not get enough sleep as a result of the state that they're in, not only disease-wise, but just given the situation that they're in. So, for example, ICU patients may have labs taken from them early in the morning, which may break up their sleep cycle a little bit, have medications administered to them at random times during the day, which may not promote a continuous circadian rhythm, which is why management of insomnia and other sleep disorders is important in these patients. You may see patients that have metabolic abnormalities, and one common one that comes to mind is hypoglycemia or even hyperglycemia. And patients who have withdrawal from other medications such as benzodiazepine or opioids may have potential risk of developing delirium. In addition to all of these factors, pain and agitation may also contribute to delirium as well. Whenever you add in all the different causes of what may cause pain and agitation to that factor, to these factors, you see that there are many different pathways where you may actually develop ICU delirium. And in terms of ICU patients specifically, a lot of ICU patients will have at least one of these types of factors, if not more. In terms of things that can cause pain in the ICU, some factors include turning or physical therapy. Any kind of movement of the patient in the ICU may cause pain. Patients who are mechanically ventilated may have an endotracheal tube down their throat, which is very painful, and pain may associate with delirium. You may have tissue injury as a result of surgery, which may also cause pain and as a result delirium. Patients also in the ICU have many different lines and axis, such as central lines and peripheral lines, which may cause them discomfort. And they may have some kind of affective component to their pain as well, such as this pain means that I'm more likely to die. So that sort of affective component can contribute to pain and contribute to delirium. In terms of the things that can cause agitation, physical restraint may cause patients agitation, as we don't want the patients to necessarily move too much if they're hemodynamically unstable, for example. Patients who are on the ventilator and having breaths essentially breathed for them may develop some agitation because they're not able to breathe on their own. Also, other different psychiatric disorders such as anxiety, frustration, may cause agitation and contribute to delirium. Also, a lack of homeostasis in terms of the patient's eating and drinking may be potentials to cause agitation and delirium. Think about whenever you do not eat for a while. Some people may term that as getting hangry. And as a result of this loss of or gain of hunger and thirst, you may develop agitation and potentially delirium. Also, patients who have trouble breathing may get very anxious and have delirium as well. Pain, agitation, and delirium are very intertwined, and that's actually why the delirium guidelines also include pain and agitation. However, for the focus of today's talk, we're going to be focusing primarily on delirium. So some clinical features of delirium include, as we've talked about before, acute onset. And acute onset is the most important cause of ICU delirium. So the onset is not chronic, as with a typical patient who may have dementia or Alzheimer's disease. It has to be some kind of difference between what they were before and what they were after. As we mentioned, delirium may also have a fluctuating course going from hypoactive to hyperactive states. Patients may have inattention and may not be perceptive to reality. They may have some kind of disorganized thinking, which we'll discuss a little more whenever we talk about the different monitoring tools for delirium. They may have an altered level of consciousness, some cognitive deficits. They may have perceptual disturbances, not knowing necessarily a person's name who they might have known before, such as a family member or friend. They may have emotional disturbances. They may appear very anxious, very agitated. They also have altered sleep-wake cycles, as we talked about earlier with patients that are in the ICU constantly having their sleep disturbed. And sometimes they may actually have psychomotor disturbances as well. In terms of delirium, there are some risk factors that may predispose a patient to developing delirium. One of these is pre-existing dementia. So think about patients who have dementia or Alzheimer's disease, and think about the state that they're in at the time that they have dementia or Alzheimer's disease. This may intertwine with the potential of developing delirium later, as the patient already has some kind of baseline neurocognitive deficit. A history of hypertension is also a risk factor. And while the guidelines don't specifically say why a history of hypertension may cause or may be a risk factor for delirium, if you think about it, patients who have hypertension, whenever your blood vessels are vasoconstricted, you may not be getting enough blood to the brain at very, very high blood pressures. So as a result of this clamping down on the vasculature, you may not have enough delivery of blood to the brain, and that can cause anoxic brain injury potentially. A history of alcoholism is also a risk factor for delirium, and I think this one goes kind of without saying that patients, whenever they're on alcohol, may have some kind of neurological deficits, and those neurological deficits can actually be amplified if the patient's a chronic alcohol user and then suddenly stops drinking. Also, patients who have high severity of illness at admission may be a risk factor for developing delirium. So as we talked about with the different causes of delirium previously with the New England Journal diagram that I showed you, patients who have more of those different factors, including severity of illness, such as patients who have sepsis, for example, may have a higher risk of developing delirium. There's also some data out there that suggests that benzodiazepine usage may be an increased risk factor for delirium, which is actually why you may see many ICU physicians avoid the use of benzodiazepines in the ICU population. However, there are a few indications where you would want to use a benzodiazepine versus another agent, and we'll talk about those soon. There are many different delirium types out there, and in terms of what we want to get out of knowing about delirium, there are actually three main ones that we think about. Those are the hyperactive, the hypoactive, and mixed types. So hyperactive is characteristic with symptoms of vigilance as well as agitation. So think about the video that you may have just watched from the beginning of the presentation with the YouTube video. This patient exhibited hyperactive delirium because they were very, very agitated. However, this is not the main type of delirium that exists. Hyperactive delirium is actually the least common type of delirium that exists, and only accounts for about 1 to 2% of overall delirium population. This is very, very different than the hypoactive and the mixed types. The hypoactive is more common than the hyperactive delirium type. However, the hypoactive type is commonly overlooked by nurses, physicians, as well as pharmacists, because hypoactive means essentially symptoms of lethargy and decreased motor activity. And whenever you think about patients who are in the hospital or even patients that are in the ICU, a lot of patients will actually exhibit these types of symptoms. It doesn't necessarily mean that they have delirium, but it could be one of the big hints that this patient may have some type of underlying delirium there. And you can actually determine whether or not this is a delirium state using the monitoring tools we'll talk about after this slide. And these patients actually have been found to have a higher mortality compared to the hyperactive patients because they're not as recognized as the hyperactive patients. Then you also have the mixed type, which is more common, like the hypoactive, compared to hyperactive delirium. And in terms of their incidence, mixed and hypoactive are the most common, comprising about 49% each of delirium states. So that will comprise a total of 98 whenever you're looking at hypoactive and the mixed delirium types. Hyperactive, again, is only about 1 to 2%. And what mixed delirium is essentially having symptoms of both the hyperactive and hypoactive state. So essentially, these patients with mixed delirium may be fluctuating a lot between hyperactive and hypoactive states based on their specific patient factors and the different causes of delirium that they may have underlying. So you may be asking how you diagnose delirium, given that there's a wide variety of constellations of symptoms as well as risk factors and clinical features. There are two diagnostic tools that are validated for the use of diagnosing ICU delirium, and those are the confusion assessment method for the ICU or CAM-ICU, as well as the intensive care delirium screening checklist or ICDSC. And these have high sensitivity and specificity according to the 2013 PAD guidelines for diagnosing ICU delirium. And we'll talk about each of these and how you can actually use these as a pharmacist to help diagnose ICU delirium. So the CAM-ICU is a tool that assesses for delirium at a specific time point. So it's not over a period of time, but at one time. Again, like we said before, it has a high sensitivity and specificity for diagnosing delirium. And it has either a positive or a negative result. Positive meaning yes, the patient has delirium, or negative meaning no, the patient does not have delirium. It's important to note that the CAM-ICU does not distinguish between hyperactive and hypoactive delirium, and it does not establish a degree of delirium. And we'll discuss why now. If you actually look at the CAM-ICU Delirium Assessment, it's comprised of 4 different questions that are asked. So to be positive for delirium, you have to say yes to questions 1 and 2, and you have to either have questions 3 or 4 be a yes to be considered positive for ICU delirium. So going through this really briefly, question 1 concerns acute change or fluctuating course of mental status. So if you ask the question, is there an acute change from mental status baseline, or has the patient's mental status fluctuated during the last 24 hours? If you say yes, then you go to question 2 for further assessment. If you say no to this question, then a diagnosis of delirium cannot be made, as an acute change or fluctuating course is required to diagnose delirium using the CAM-ICU. The next step, if you did say yes to question 1, is inattention. So you can ask the patient to squeeze your hand whenever you say the letter A. So you read them a sequence of letters, so S, A, V, E, A, H, A, R, T. And you don't do it necessarily as fast as I just read it out, but you give them a little time to be able to respond. And you need to notate each of the errors that the patient may have with this command. So say if they do not squeeze on the letter A, or if they squeeze on a letter other than A, that's considered an error. So if you have more than 2 errors, then you go down to question 3. If you only have 0 to 2 errors, then at this point you can call the patient CAM-ICU negative, and they are negative for delirium, and you don't need to go any further in the assessment. So question 3 is determining whether the patient has an altered level of consciousness. So this is actually done using the RASS scale, and what the RASS scale is the Richmond Agitation and Sedation Scale, which will measure how sedated a patient is or how agitated a patient is. And this scale, ideally, you want to be at 0, which 0 is correlated to alert and calm. If you're in the negative numbers, such as from -1 to -5, that means the patient is sedated. And when you go further away from 0, that means that they are heavily sedated. So, for example, -5 is more sedated than a -3. You also have on this RASS scale the potential for going above 0. And if you go above 0, that means the patient has some kind of degree of agitation, with a 1 on the RASS scale being a light level of agitation compared to, for example, a 4 on the RASS scale, which would be a high level of agitation. So what you want to do is assess their RASS level. If their RASS level is anything other than alert or calm, or a 0, then you can term that patient CAM-ICU positive. And if the patient is CAM-ICU positive, delirium is present. However, if you determine that the patient is alert and calm, or a RASS of 0, then you go to step 4, disorganized thinking. So step number 4 comprises of different questions that are based on logic. So these are questions essentially that almost anyone can answer, even potentially, an elementary school student. So questions that you can ask are, will a stone float on water? Are there fish in the sea? Does 1 pound weigh more than 2? And can you use a hammer to pound a nail? If you have 0 to 1 errors or incorrect answers with any of these questions, then you can be considered CAM-ICU negative and have no delirium. However, if you have more than 1 error, so two or more errors on any of these questions, that is what is considered CAM-ICU positive. Now, say if the patient is not able to talk for some reason, you can actually give them commands, as you see here, and essentially the same rules apply with the amount of errors. So again, just to recap, the CAM-ICU scoring is positive or negative according to the presence or the absence of the criteria listed. So you have to have criteria 1 and 2, as well as criteria 3 or criteria 4. And the patient has to be sufficiently awake to do the CAM-ICU assessment. So a RASS score of -3 or more. So -3, -2, -1, 0, 1, 2, 3, or 4 would qualify for this. The ICDSC is another tool that has high sensitivity and specificity for diagnosing delirium. Now, compared to the CAM-ICU, the ICDSC assesses for delirium over a period of time, compared to the CAM-ICU, which is only at one time point. So this is an important difference to note between CAM-ICU and ICDSC. Like the CAM-ICU, it does have a positive or negative result. So yes, I'm positive the patient has delirium, or no, or negative, the patient does not have delirium. Like the CAM-ICU, it does not distinguish between hyperactive and hypoactive delirium. And unlike the CAM-ICU, it does establish a degree of delirium because there's actually a numerical score that is associated with the positive or the negative result. So this is what the ICDSC looks like. Now, in terms of the CAM-ICU and the ICDSC, I'm not going to have you memorize each of the specific questions that are related to these assessments, but I do want you to know the information about the characteristics of the CAM-ICU and ICDSC that are discussed on the slides. So if you look at the actual diagnostic criteria that the ICDSC has, some of them are actually similar to the CAM-ICU, such as the altered level of consciousness, as well as the inattention pieces. And there are some other things in the ICDSC that are also included, such as sleep-wake cycle disturbances, or inappropriate speech or mood, psychomotor agitation or retardation are also listed here, for example. And whenever you look through each of these criteria, you have to answer yes or no, depending on what criteria you're on. So you can have a score of 1 assigned to a yes answer and a score of 0 assigned to a no answer. So you complete each of the 8 questions on here over the period of time that you are doing the ICDSC, and typically it's a nursing shift. And you circle each of the answers and then tally them up. And that will give you a numerical score from 0 to 8. In terms of what that numerical score actually means, a score of 4 or more is positive for delirium. So it's essentially almost equivalent to an CAM-ICU positive. A score of 1 to 3 may be termed as subsyndromal delirium. So what subsyndromal delirium is it's a patient who may not be diagnosed with ICU delirium, but has significant risk factors and characteristics of patients who have ICU delirium. However, at this point, with a score of 1 to 3, they are not considered ICU delirium. And it's kind of similar to the CAM-ICU. A patient must show response to mild or moderate stimulation. And it doesn't necessarily have to be stimulation via touch, but it has to at least be stimulation via speech or some kind of response. So this criteria is almost similar to the requirement for a RASS of greater than -3 to be needed for the CAM-ICU. In terms of delirium treatment, there are many different non-pharmacological and pharmacological methods you can use to treat delirium. So some non-pharmacological methods you can use are repeated reorientation. So telling the patient who they are, where they're at, and what exactly is going on. It may help keep the patient in reality and away from trying to develop a delirious state where they may not necessarily be in reality in their minds. Also, cognitive stimulation. So potentially doing things with the patient, such as reading to them, interacting with them, just checking on them to see how they're doing may help prevent delirium. Vision and hearing aids are also important for patients who may need them. So say, for example, if you're a person who wears glasses, and if you did not have your glasses on for some reason, would you be able to see as well? Or say if you're a person who has a hearing aid and whenever you come to the hospital, your hearing aid is taken out, would you be able to hear as well? It's important to maintain as much of the senses as possible for the prevention of ICU delirium, because without these potential visual and hearing aids, patients may lose a little bit of touch with reality. Adequate hydration is also important for delirium prevention. So say if you have a patient who comes in who's dehydrated or has dry mucous membranes, for example, and their labs show that they may have risk of dehydration with their BU and serum creatinine ratio, that may be a predisposing factor for delirium that you may want to correct with hydration. In addition, the last 3 are actually ones that have recommendations in the delirium guidelines, such as light and noise reduction. And if you think about patients that are in the ICU, there are many lights as well as many noises that are going around. So trying to minimize these lights and noises, particularly at the nighttime whenever they need sleep, is very important to try to minimize ICU delirium. Early mobilization is another big component of non-pharmacological delirium prevention. Trying to get the patient up and even out of bed just to sit in a chair can be very, very beneficial in preventing ICU delirium later on. So trying to get these patients up and moving and not constantly stagnant in one place may help prevent delirium. Another factor that you may want to consider is sleep promotion, as we talked about earlier. As we are pharmacists, we should be aware of what the different pharmacological agents that contribute to delirium are. So many of these do have some kind of effect neurologically on a patient and may predispose the patient to developing delirium. So sedative hypnotics is one of the big classes of drugs that may contribute to delirium. So many of the different agents that we talked about in the sleep disorders talks are drugs that can potentially cause delirium. Narcotics, particularly opioids, can be agents that may contribute to delirium. Anticholinergic agents, particularly in the elderly population, may contribute to delirium. So those agents are agents such as Benadryl, Doxepin, etc. Patients who are on corticosteroids also may have risk of developing delirium, especially when those corticosteroids are at high doses or on for prolonged periods of time, such as when patients are in sepsis and may need corticosteroids to keep their blood pressures up. Treatment with multiple drugs, as well as many different drug interactions, can also potentiate delirium, as well as alcohol or drug withdrawal. And this also includes benzodiazepine withdrawal within this subset. So patients who have some kind of withdrawal syndrome may be at higher risk of developing a delirious state. When you're assessing delirium, it's important to identify and address predisposing and precipitating factors for delirium. So whether that be a disease state, a drug, something environmentally going on like loud noises or light exposure, it's important to identify those different factors and then minimize them where possible. As pharmacists, we should review medications that have potentiation of causing delirium. And this can include prescription medications, PRN medications, OTC medications, as well as herbal medications. Once we've reviewed those medications, it's important to remove or alter potentially harmful drugs, i.e. changing to less noxious substances or alternatives, decreasing doses where applicable. And if you think about the Beers criteria in the elderly population, this is one of the big recommendations that you can do as a pharmacist, as well as using the non-pharmacological approaches, which we just talked about. There are a few different potential agents for the treatment of delirium, and these include your typical antipsychotics, your atypical antipsychotics, your cholinesterase inhibitors, as well as dexmedetomidine or Precedex. So the ones that you may be familiar with already from your previous TBL sessions include the typical antipsychotics, atypical antipsychotics, and the cholinesterase inhibitors. You may or may not have seen Precedex before or dexmedetomidine, but we'll talk about it a little more in detail. So just to refresh and go over each of these different agents again, just kind of as a brief overview, to get an idea of the role that they play in delirium, as well as some of the factors you have to take a look at. Let's start with haloperidol. So as you know, haloperidol is a typical antipsychotic, and it works on the D2 receptor, causing antagonism, so no activity essentially. And this may play a benefit in delirium. It has many different dosage forms available, and the dosing, as you see, is here. It does have potential for being involved in many different drug interactions, as it is a substrate of CYP3A4 in the CYP system in general. And some side effects that you may see with haloperidol include QT prolongation, which is one of the biggest concerns that we have, particularly in an ICU population. The EPS symptoms, which Dr. Wayne talked with you a little bit about. Haloperidol may also cause sedation as well as postural hypotension, which means that if you have a patient who is receiving haloperidol, it may be wise to tell them to hold on to something whenever they're getting up or going back down onto their bed. The atypical antipsychotics are the 5-HT2A and D2 receptor antagonist. And remember from the pathophysiology of delirium that these two neurotransmitter systems may play a role in the development of delirium, so antagonizing these may be beneficial. Atypical antipsychotics include many different agents such as quetiapine, aripiprazole, olanzapine, and risperidone, but those are not the only agents that you may potentially see used for delirium. It does have less incidence of extrapyramidal symptoms versus haloperidol, and the QT prolongation is still present compared to haloperidol, so that's very, very important to note. And like haloperidol being in the CYP family, Atypical antipsychotics also have many drug interactions related to them. This is just a general chart of the antipsychotics. I know that y'all know a lot of this information that exists here. These just include some of the basic adverse effects as well as the different considerations that you may use to determine which agent you would actually give a patient in practice. Another agent that may be used is rivastigmine. Rivastigmine is a cholinesterase inhibitor, and it's typically used in patients with dementia or Alzheimer's disease, and it's available as a tablet or a transdermal patch. As you see here, the dosing of the tablets and the patch are included. It's important to note the side effects of these medications, particularly in an elderly population, such as dizziness, headache, nausea, as well as weight loss. And the last agent we'll discuss in terms of the treatment of delirium is dexmedetomidine or Precedex. Precedex is an alpha-2 agonist similar to clonidine and can be used in mechanically ventilated and non-mechanically ventilated patients as a sedative. It is only available IV, and the dosing ranges from 0.2 micrograms per kilo per hour to 1.5 micrograms per kilo per hour. The units on this dosing are important to remember because standard dosing for many drips is mics per kilo per minute. However, with Precedex, it's mics per kilo per hour, and that's important to note. Some side effects of dexmedetomidine include hypotension or hypertension, as well as bradycardia. So what you predominantly see in terms of the blood pressure is that you may see more hypotension throughout the long haul whenever you're using Precedex. You only will see hypertension typically at the beginning of the Precedex infusion. And some people may think that this is the compensation for the hypotension that's about to develop. But predominantly, the main side effect is hypotension as well as bradycardia. Unlike a lot of the other sedatives, Precedex does not have any significant respiratory depression associated with it. So whenever you think back to the status epilepticus lecture that we talked about, midazolam, propofol, pentobarbital, and ketamine, all of which required mechanical ventilation. Precedex is one of the only continuous infusion sedatives that does not require mechanical ventilation, though a patient can be mechanically ventilated and on it. So now that we've talked about all of the different drugs, as well as the presentation and pathophys of delirium, as well as the monitoring tools, let's go over now what the evidence-based recommendations are for the treatment of delirium. These guidelines are actually the Pain, Agitation, and Delirium Guidelines from 2013. By Barr and colleagues, and these were published in Critical Care Medicine. They have many different recommendations for pain, agitation, and delirium. However, we'll only be focusing on the delirium piece of this. So the guidelines address each of these different factors, which will be important to know in how you treat or prophylax against delirium. So they include delirium prophylaxis. So basically, trying to prevent delirium in a patient who doesn't have delirium yet. Delirium treatment in patients who have a high risk of torsade points or a prolonged QT interval, as well as delirium treatment in patients who require mechanically ventilated sedation. So the first recommendation we'll talk about is the delirium prophylaxis recommendations. So for delirium prophylaxis, pharmacotherapy prophylaxis is not recommended with haloperidol or atypical antipsychotics, and both of these are 2C recommendations, so they're not very great. In terms of prophylaxis with dexmedetomidine or Precedex, There is currently no recommendation for or against the use of Precedex in delirium prophylaxis. For treatment of delirium with haloperidol or atypical antipsychotic agents like quetiapine, ziprasidone, risperidone, or olanzapine, for the treatment with haloperidol, per the guidelines, there is no published evidence showing reduction in the duration of ICU delirium. So it's not a guideline-based practice, though many doctors as well as clinicians will do this anyway because they may believe it works. And clinically and anecdotally in practice, it may work. However, the guidelines don't have any published evidence showing that this will work. And the treatment with atypical antipsychotics may reduce the duration of ICU delirium, and this is a grade C recommendation. The reason for this recommendation specifically actually came from a landmark trial that was published in 2010 by Devlin and colleagues entitled The Efficacy and Safety of Quetiapine in Critically Ill Patients with Delirium. And this was a prospective, multi-center, randomized, double-blind, placebo-controlled pilot study. How Devlin and colleagues designed the study was that they included 36 adult ICU patients above the age of 18 with delirium diagnosed via the ICDSC scale. And they looked and compared patients who received either quetiapine 50 milligrams by feeding tube every 12 hours versus placebo. If PRN Haldol was needed in the previous 24 hours to reduce an episode of agitation, they reduced the quetiapine dose by 50 milligrams per day. And this quetiapine dose was titrated up to a maximum of 200 milligrams daily. Their overall objectives were to compare the efficacy and safety of this practice compared to placebo. What Devlin and colleagues found from this study was that quetiapine had a shorter time to resolution of ICU delirium. In the quetiapine group, the duration to first resolution of delirium was 1 day, versus in the placebo group where it was 4.5 days, and it was statistically significant. Also, they saw reduced duration of delirium with quetiapine, less agitation by the sedation agitation scale, or the SAS scale, the SAS scale. However, whenever you compare mortality benefit between the groups, mortality was actually similar between groups at 11 to 17%. And when you looked at ICU length of stay between the groups, it was similar, 16 days versus 16 days, not statistically significant. Moving on to our next guideline recommendation, they do make mention of the cholinesterase inhibitors such as rivastigmine for the treatment of ICU delirium. And their recommendation in the guidelines is that rivastigmine is not recommended for the treatment of ICU delirium. However, they do make note that rivastigmine may be useful in treating delirium in demented elderly patients. So essentially, if the cause of delirium is an underlying dementia or an Alzheimer's disease, rivastigmine may prove of benefit in this patient population. However, if you don't have a patient that has dementia or Alzheimer's disease, rivastigmine is not recommended. And they actually showed trends toward higher mortality and longer delirium duration with rivastigmine. So rivastigmine is not an agent that we typically see used for ICU delirium. However, it is mentioned in the ICU delirium guidelines, and it may be useful for patients who have dementia or Alzheimer's disease. The next recommendation concerns patients at high risk of torsades. So to have an idea of what torsades is, you have to have an idea of what can potentially provoke torsades occurring. So remember, torsades is a twisting of points that's seen on the EKG, and this is a fatal cardiac rhythm. And it can be a result of having a prolonged QT interval. So some people may have different definitions of QT intervals that you may see in practice. One source notated a QT interval being prolonged if it was greater than 470 milliseconds in females and greater than 450 milliseconds in males. Though a lot of times you may see in practice where 500 will be the cutoff for both males and females. And this is actually what I use in practice as a determinant to determine a prolonged QT interval. Whenever you have patients with prolonged QT intervals, so greater than that 500 milliseconds, you should analyze to see if they're on any other concomitant QT prolonging medications. So things such as amiodarone, the macrolide antibiotics such as azithromycin and erythromycin, azole antifungals like fluconazole, fluoroquinolones such as Levaquin or Cipro. Patients who have HIV who are on ritonavir or protease inhibitor regimens may be at risk of a prolonged QTC interval, as well as Bactrim and dexamethasone. It's important to identify patients who have a prolonged QT interval, such as that greater than 500 milliseconds in a male or a female, because if you give a patient an antipsychotic which prolongs the QT, such as haloperidol or any of the atypical antipsychotics, it actually may prolong that QT and put them at risk of torsades. As a result of this, the guidelines do not recommend the use of antipsychotics in this population. Now, despite the fact that the guidelines do not recommend the use of antipsychotics for patients with torsades, sometimes in practice you may see these agents still be used anyway, particularly Abilify and olanzapine or Zyprexa. And the reason why you may see Abilify or olanzapine used specifically is because these agents have little to no risk of QT prolongation. Now, despite the fact that these agents have little to no risk of QT prolongation, it's still recommended in the guidelines to not use these agents at all. Moving to the guideline recommendations on mechanically ventilated sedation. In terms of mechanically ventilated sedation, the guidelines prefer to use continuous IV infusion dexmedetomidine versus benzodiazepine infusions in patients who require sedation for mechanical ventilation. And some data has actually shown Precedex to be associated with a significant daily reduction in delirium prevalence. However, there is one exception or actually a few exceptions where you would not use dexmedetomidine, and that would be in patients who have alcohol or benzodiazepine withdrawal. So patients who have alcohol or benzodiazepine withdrawal actually need that GABA agonism so that the alcohol or benzodiazepine withdrawal can be minimized or stopped. So this would be one exception to the rule where you want to avoid benzodiazepines in general for delirium. If the delirium is a result of alcohol or benzodiazepine withdrawal, then give a benzodiazepine. It's also unclear if benzodiazepines increase the risk of delirium in the trials that analyzed dexmedetomidine. So kind of going off of this recommendation, there was actually a new study that was just published this year in 2016 called the DahLIA trial, which is the effect of Precedex or dexmedetomidine added to standard care on ventilator-free time in patients with agitated delirium. And you may actually be wondering what DahLIA means. DahLIA essentially is a term for the dexmedetomidine to lessen ICU agitation study. And this was a study done by Reed and colleagues. This study looked at 74 adult ICU patients intubated in whom extubation was considered inappropriate, secondary to agitation or delirium severity. So whenever they're trying to extubate a patient, if the patient has a lot of agitation, especially whenever they're trying to pull a tube out of their throat, it can be very, very dangerous, not only for the providers that are trying to extubate the patient, but also for the patient themselves, because it may be potentially a dangerous situation. What this study looked at was dexmedetomidine versus placebo, or normal saline. So they looked at a rate of dexmedetomidine of 0 to 1.5 mics per kilo per hour. And what they did was they titrated the dexmedetomidine or the saline to achieve a RASS of 0. So essentially that alert or calm patient, or to a physician prescribed goal. And they also wanted to look at efficacy and safety outcomes. Some of the selected results that I picked out of this study were that Precedex actually had a shorter time to extubation compared to placebo, 21.9 hours versus 44 hours. So essentially almost a full day. There was also a quicker time to the first absence of delirium using the CAM-ICU. So 23 hours versus 40 hours. However, whenever you look at the ICU and hospital length of stay between the groups post-randomization, there was no statistically significant difference. Though these differences that you see here, 2.9 versus 4.1 and 8.5 versus 9.5, may be clinically significant, considering that each of these is at least a full day. In terms of our overall conclusions for today's discussion on ICU delirium leads to increased morbidity and mortality, and non-pharmacological modalities should be implemented prior to the use of pharmacotherapy. The choice of pharmacotherapy is, though, limited only to certain agents that show benefit, such as Quetiapine as well as Dexmedetomidine. The other agents do not have any randomized controlled data to suggest that they actually work in the treatment of delirium. This is a little bit of a schematic that I actually put together to kind of give you an idea of where each of the different treatments falls for the treatment of delirium. So you start here at the top and ask yourself, does the patient have possible ICU delirium? If yes, then you can assess the patient using the CAM-ICU or the ICDSC scales. If the patient is negative at that point using either one of the scales, you should assess for ICU delirium every nursing shift. If the patient is positive using one of those scales, you should do non-pharmacological management first and assess a QTC at that point. So obviously you're looking for if that QTC is greater than or equal to 500 milliseconds, which can potentially preclude some of your antipsychotic agents from being used. Now, later in the nursing shift, if you see that your patient is still in ICU delirium, or even on the next nursing shift, you may consider an antipsychotic at that point if your QTC is less than 500 or within normal limits. If at that point you are delirium negative, you should continue the non-pharmacological management and assess for ICU delirium every nursing shift. Now, if your patient does have delirium at the second check and you've already done the non-pharmacological methods and the patient is sedated, for example, then you can consider Precedex or Dexmedetomidine to be used versus the benzodiazepine agents. Unless you have a patient who has alcohol or benzodiazepine withdrawal, and that is what you think is the main cause of the delirium, then in that case you should use an IV benzodiazepine such as Versed or lorazepam. So this schematic or treatment approach will be very important to know in order to adequately treat a patient with ICU delirium. Here are the references for this talk. So remember our patient SW who came in, who developed hyperactive delirium post his extubation. The first question we had was, which of the following types of delirium does SW most likely have? The answer here is hyperactive delirium, because the patient, as we saw in the case here, was very agitated, thrashing around, and wanting to take out his nasal cannula. So that's why hyperactive delirium would be the most appropriate answer here. Hypoactive delirium would be more associated if the patient actually had lethargy or decreased motor activity. And per the case, it says he is not lethargic and has adequate motor activity, which would make hypoactive less likely. This patient may potentially have mixed delirium. However, because they don't have the evidence of hypoactive delirium, mixed delirium is less likely on the differential for this patient. And we did not mention that the patient had any predisposing dementia or Alzheimer's disease. Otherwise, then dementia could be potentially a cause of the patient's delirium. The second question is, which of the following non-pharmacological interventions is most likely to benefit SW's delirium? And the answer to this question is reorientation. So essentially telling SW who he is, where he's at, why he's there, even, potentially, trying to get him reoriented back to what he was doing before. So maybe, asking him to sleep, maybe asking him to do an activity with you, etc. These are all elements that can help you reorient SW. Staying abed and avoidance are two elements that would not help to treat SW's ICU delirium. Actually, early mobilization can help with ICU delirium, and interaction with other people can also help to prevent ICU delirium. Hydration versus dehydration can actually help with patients in ICU delirium, because dehydration may be a potential cause of ICU delirium. And the last question we have is, which of the following agents is most likely to be beneficial in the treatment of SW's ICU delirium, assuming no contraindications? And the answer to this question is quetiapine. As we mentioned, quetiapine is an atypical antipsychotic and has been shown in the 2013 PAD guidelines via the Devlin study that we just discussed to actually be beneficial for the treatment of ICU delirium. SSRIs, as well as TCAs such as amitriptyline, should not be used in the treatment of ICU delirium, and sometimes these agents actually may worsen ICU delirium as they are psychoactive medications. Alprazolam is actually a potential risk factor for the development of delirium, as well as alprazolam or Xanax is a benzodiazepine agent. If you have any questions concerning ICU delirium before class on Wednesday, please let me know. Thanks and have a good day.